Have you ever had one of those moments, something totally unexpected, maybe a bit alarming, happens with a pet, and you just freeze, realizing you know nothing about it? Well, today we're doing a deep dive into something like that in the horse world. It's a serious condition, rectal prolapse. Our goal here is to really unpack what sounds like, a super technical vet term. We want to get to the heart of what's actually going on, understand why it's such an emergency, and look at the surprising differences between types that dictate treatment. You should walk away really understanding this condition.
Exactly, and it's fascinating because it looks like just, well, a protrusion, right? But the underlying causes can be incredibly complex, and the outcomes, they vary massively depending on exactly which tissues are involved. It really highlights the precision needed in veterinary medicine. Understanding these details gives us broader insights into animal health overall.
Okay, so let's start right at the beginning. The absolute basics. What is rectal prolapse?
Well, at its core, it's simply when tissue from the rectum pushes out through the anus of the horse.
Seems straightforward enough on the
It
surface.
does, yeah. But the how is specific.
Yeah.
It's caused by increased pressure inside the abdomen, pushing back towards the anus, usually from intense, prolonged straining. Vets call that straining tenesmus.
Ah, okay. Tenesmus.
Right. And that pressure forces the inner layers of the rectum, the mucosa and submucosa, to sort of slide backward over the outer muscle layer and then out.
And once it's out, I imagine things go downhill pretty fast if it's not fixed. What happens to that exposed tissue?
Very fast.
Right.
The longer it's exposed, the worse it gets. It swells up, that's edema,
Right.
and it turns bluish cyanotic because the blood can't drain out properly through the veins.
Okay. Nasty.
Yeah.
Yeah.
And this mainly hits the gastrointestinal system hard. You can get impaction in the prolapse bit or even tissue death, necrosis in the small colon if its blood supply gets cut off. That dead tissue can then cause severe inflammation inside the abdomen, peritonitis, or even sepsis, a body-wide infection. And behaviorally, you see the straining, obviously, and signs of intense abdominal pain. In really bad cases, especially if blood vessels are damaged or toxins get into the bloodstream, endotoxemia, you can see the horse go into circulatory shock.
And you mentioned it's more common in certain horses?
Yeah, generally seen more in adult horses and particularly in mares. Some types are very strongly linked to difficult births, dystocia.
Okay, so we've got the what and the why, but you hinted it's more complex. Not all prolapses are the same.
Not at all. That's critical. There are actually 4 distinct types, and knowing which type it is completely changes the outlook and the treatment plan.
4 types. Okay, let's break those down.
Right. It's all about which layers are involved and how far they come out. So type 1, this is often called incomplete or mucosal prolapse. Just the inner lining mucosa and submucosa protrudes. Usually looks like a swollen, reddish, sort of donut-shaped ring right at the anus, often bigger on the bottom edge.
Okay. And the outlook for type 1?
Generally good. We see success rates over 90% with prompt treatment.
That's encouraging. What's type 2?
Type 2 is a complete prolapse of the rectal ampulla, so all layers of that final section of the rectum come out. This one looks bigger, maybe more like a cylinder or even a cauliflower shape, again, often thicker ventrally on the bottom. It can look quite dark red, congested.
And the prognosis there?
It drops a bit, guarded to good, maybe 50 to 80% success. Still potentially treatable, but more serious.
Okay. Getting more serious. What about type 3?
Right. Type 3, here's where it gets complicated internally. You have all layers of the rectum protruding, just like type 2. But there's an added complication. Part of the deeper rectum, or even the small colon, has telescoped into that prolapse section. It's called intussusception.
Telescoped inside it, so you might not see that extra bit from the outside.
Exactly. Externally, it might look like a type 2. But the key difference is, if you try to gently feel around the base, you often can't pass a finger between the prolapse mass and the inner rectal wall. There's usually a distinct fold or fornix at the base because of that internal telescoping.
Ah, I see. And the prognosis?
Takes a nosedive here. Guarded to poor, much riskier.
Wow. Okay. And that leaves type 4. How does that differ?
Type 4 is similar to type 3 with that internal intussusception. But in this case, that telescope piece of peritoneal rectum or small colon actually pushes through the anus as well. It comes out external to the main rectal prolapse.
So you'd see 2 distinct structures, kind of.
You might. Often it looks like one very long tube-like mass. It's usually very large, very dark, looks really compromised. Critically, you can often feel a groove or trench between the main prolapse and the anus where that inner piece is pushed through, sometimes described like a string of sausages.
Goodness.
Yeah. This is the most severe, often seen with really difficult foalings in mares. And the prognosis is grave. Very poor chance of survival.
That jump in severity from type 2 to 3 and 4 is huge. What's happening inside with types 3 and 4 that makes them so incredibly dangerous?
It's all about the blood supply. In types 3 and 4, the entire rectum can basically detach from its surrounding tissues. This means the rectum and the end part of the small colon get displaced. Now, the tissue fold that carries the blood vessels to the small colon, the mesocolon, is quite short.
Okay.
So when everything gets displaced like that, that mesocolon often tears.
Oh, no.
Yeah. And when it tears, the blood supply to that part of the colon is completely cut off. That leads to ischemic necrosis tissue death from lack of blood. And that's what quickly spirals into life-threatening peritonitis and sepsis. It's the hidden damage to the blood supply that really defines the severity.
Makes sense. It's not just what's visible.
Not at all.
So we've established rectal prolapse is usually secondary, a symptom of that intense straining, the tenesmus. What kind of underlying problems cause a horse to strain that badly?
Right. It's almost always a sign of something else going on. Lots of potential causes. Gastrointestinal issues are a big category. Things like severe diarrhea, colitis, which you see a lot in foals. Or the opposite, constipation or impaction, like foals struggling to pass their first manure, the meconium. Also, intestinal parasites, something stuck in the rectum, tumors or polyps, inflammatory bowel disease, or really any kind of severe colic or blockage.
That's a lot just on the GI side.
It is. Then for mares, reproductive problems are major triggers. Difficult foaling, dystocia, is hugely linked to type 4, as we said, but also retained placentas, or even a prolapsed vagina or uterus can cause that kind of straining.
Right. What else?
Urinary tract problems can do it too, like bladder infections, cystitis or bladder stones, urolithiasis, or any blockage in the urethra. Less common causes could be nerve damage affecting the anal sphincter, really severe chronic coughing, or very rarely things like exposure to certain estrogens.
That's a wide range. But you also mentioned sometimes you just don't find the cause.
That's true. In some cases, it's diagnosed as idiopathic. We just can't identify the specific underlying trigger despite investigation.
That must be frustrating for owners and vets.
It can be. And it really underscores the main takeaway for owners. Vigilance is key. Watch for any excessive straining, because prolapse is usually the symptom. Catching and treating the primary problem early is the best way to prevent the prolapse from happening at all.
Absolutely. Prevention is better than cure, especially here. So let's say a vet arrives. How do they figure out which of those 4 types they're dealing with? What's the diagnostic process?
Well, the initial steps are pretty direct. A careful visual inspection and gentle palpation are crucial. That usually lets you differentiate the types pretty well and also helps rule out something like a tumor. A tumor grows from the tissue, but prolapse is the tissue turned inside out.
Okay, visual and hands-on first.
Then lab tests. Blood work, a CBC and biochemistry panel, and maybe a urinalysis. These help identify systemic issues related to the underlying cause. For example, with the severe types, you might see changes in white blood cell counts, electrolytes, things that point towards infection or dehydration.
Makes sense. What about looking inside?
We can do what's called an abdominocentesis, taking a small sample of the fluid from the abdominal cavity.
A belly tap.
Exactly. We look at that fluid for signs of trouble with the small colon, like increased white cells or protein. Though, sometimes those changes don't show up until necrosis or peritonitis is already underway.
Right, any imaging.
Transabdominal ultrasound can be useful. It can show if there's free fluid in the abdomen or help assess how the intestines are moving. For the really serious type 3 and 4 cases, we often need a better look inside to see the extent of the damage, especially to that mesocolon and small colon. That might mean more invasive procedures like exploratory surgery either through the flank or a midline incision on the belly, or ideally, laparoscopy.
Using a camera.
Yeah, a small camera inserted through tiny incisions. It gives great visualization, especially if done with the horse standing, and it's much less invasive than full surgery.
Okay, so diagnosis involves a mix of observation, lab work, and potentially imaging or even surgery. Once the type and severity are clear, what about treatment? I imagine it varies wildly.
Hugely. And speed is absolutely critical. Prompt vet care is paramount. The very, very first step, always, is stopping the straining. That's usually done with an epidural anesthetic. Blocks the nerves back there.
Okay.
Heavy sedation helps too, or even topical lidocaine gel applied directly.
What about first aid? If an owner finds this, what can they do before the vet gets there?
Great question. Practical steps are vital.
Right.
First, keep the horse as calm as possible. Try to prevent them from lying down or rubbing the prolapse against anything.
Right, protect the tissue.
Exactly. Gently clean it if you can, with a mild antiseptic solution and water. Then lubricate it really well with sterile lube, like obstetric lubricant, and try to reduce the swelling. Applying something hypertonic, like concentrated sugar solutions, 50% dextrose if you have it, or even just plain table sugar in a paste can draw fluid out.
Sugar, really?
Yep, or cold hosing for maybe 15-30 minutes. And gently support the mass with a clean, lubricated hand or towel if possible. Don't let it just hang and get traumatized.
Good practical advice. So once the vet takes over, what are the treatment paths? Let's start with the less severe types.
Okay. For type 1 and early type 2, if the tissue still looks viable, hasn't been out too long, hasn't got severe edema or trauma, conservative therapy often works. This involves reducing that swelling, maybe using topical glycerin, mannitol, or magnesium sulfate paste, then carefully pushing the prolapse back in. Manual reduction.
Okay, push it back in, then what? Does it just stay?
Usually not on its own initially.
Yeah.
So we often place what's called a purse string suture around the anus.
Like cinching a bag closed.
Kind of, yeah. Uses strong, non-absorbable suture material, placed in a circular pattern just outside the anus. The key is it needs to be tight enough to prevent the rectum from prolapsing again, but loose enough usually so you can still get 2 or 3 fingers in to allow the horse to pass manure.
Ah, that's a balance.
Definitely. You often have to manage defecation, maybe manually remove feces or temporarily open the suture every few hours. It typically stays in for just a couple of days, maybe 48 to 72 hours.
And after reduction.
The horse is usually kept off feed for about 24 hours. Then given mineral oil or laxatives for at least a week and put on a soft laxative diet for maybe 2 weeks to keep stools soft. And often they're kept cross-tied in a stall for the first week to stop them lying down, which increases that abdominal pressure.
Okay. What if conservative therapy doesn't work, or it's a more chronic type 1 or 2?
Then surgery might be needed. Options include submucosal resection, where just the damaged inner layers are removed, or a full-thickness partial rectal amputation. The submucosal resection is generally preferred if possible. It saves the muscle layers and blood supply, keeps the surgical field cleaner, and has fewer risks like abscesses or the rectum narrowing later on, which is called a stricture.
Got it. No, the scary ones.
Yeah.
Type 3 and 4, you said surgical emergency.
Absolutely. These need a referral to a surgical hospital immediately. They often need IV fluids right away for shock or dehydration. The treatment is surgical amputation of any dead or non-viable tissue. Then the healthy ends of the bowel are stitched back together. That's called anastomosis.
Major surgery. Right.
Very major. Often, they'll also do a coeliotomy, open the abdomen to assess everything internally and maybe perform a colopexy.
Colopexy.
That's where they surgically tack the colon to the inside of the abdominal wall to help prevent it from prolapsing or insuscepting again.
Wow.
In the most severe type 4 cases, sometimes the damage is so bad that a permanent colostomy is the only option, rerouting the bowel to an opening on the horse's side. But that's a salvage procedure with significant management challenges.
And throughout all this, you still have to address the original cause of the straining, right?
Paramount.
Yeah.
Absolutely critical. Whatever the treatment for the prolapse itself, you must treat the underlying issue. So that means fluids and antibiotics for diarrhea, fecal softeners for impaction, deworming, managing the foaling, whatever it might be. Otherwise, it's likely to just happen again.
Makes total sense. And post-treatment, what's the follow-up?
Close monitoring, watching for any more straining, signs of impaction or relapse, continuing fecal softeners, pain relief, usually NSAIDs. Broad-spectrum antibiotics are common to prevent infection. Remove the purse string suture within about 3 to 7 days, usually. And for the type 3 and 4 cases, vets might do repeat abdominocentesis, those belly taps, to monitor for internal complications like peritonitis.
So after all that, what's the bottom line for the horse and owner? What are the real chances of recovery?
Well, as we said, it really depends heavily on the type. For type 1, the prognosis is generally good. Over 90% success is typical with appropriate treatment. For type 2, it's more guarded, but still potentially good, maybe 50 to 80% success.
Okay.
But for type 3 and 4, the prognosis is poor to grave. These are truly life-threatening emergencies. Survival rates are low, even with aggressive surgery. The risk of complications like severe tissue death, peritonitis, and sepsis is just incredibly high.
That really drives home the message, doesn't it? Early recognition, protecting that tissue immediately, and getting veterinary help fast are just absolutely crucial. It's a race against time, particularly for those hyoid types.
It absolutely is. And owners need to be prepared for difficult conversations, especially with type 4, depending on the severity, the horse's value, the owner's resources and goals. Euthanasia is sometimes the most humane option. If treatment is attempted for type 3 or 4, the vet needs to have a very frank discussion about the high costs, the intensive aftercare required, and a long list of potential serious complications. Things like reprolapse, impaction, suture lines breaking down, abscesses, rectal strictures, more tissue necrosis. It's a very tough road.
Understood. It's complex, potentially devastating, but knowing the types and the urgency makes a huge difference. So there we have it. We've really gone deep today. From what seems like a simple, if alarming issue, we've uncovered all these layers, the four distinct types, the critical role of blood supply, the link to straining, and all those underlying causes. You definitely have a much deeper understanding now than just tissue sticking out. It gives you a real appreciation for the complexities involved.
It really does. And it makes you wonder, doesn't it? What other conditions out there seem straightforward on the surface, but hide these dramatic, life-threatening complexities just underneath? It highlights how interconnected everything is in the body and how important it is to pay attention to those seemingly small signs, like straining, that can actually be major alarm bells.
A great final thought. Keep observing, keep asking questions, and keep diving deep. Thanks for joining us for this deep dive.